With Mike Callahan, who I've been working with since way back in 2008, related to PSO and the PSQIA. It's such an exciting and important topic we're talking about today. It's how to create a safe and privileged space for learning and improving patient outcomes through a patient safety evaluation system. You wouldn't believe that I believe it's as exciting as it is, but I think this is critical, and I think it's a gap for many organizations. In preparation for this webinar, we did a survey, and disappointing, the number of organizations that had not yet defined and documented their patient safety evaluation system. It really takes me back to the whole reason for PSQIA and really the government, I believe's intent to really create a just space for learning in healthcare organizations. I really believe that organizations that haven't defined their PSES or believe that their PSES is their event reporting system, they're really not taking advantage of defining a safe space to learn and improve patient safety, healthcare quality, and outcome. And today, Mike and I are going to talk about how you would go about doing that. Next slide. So we have nothing to disclose. This is our standard disclaimer. The opinions today are those of Mike and myself. They don't reflect anyone else's. They're not ARC's opinion. They're not. Next slide. Mike, do you want to introduce yourself?
Sure. Just briefly, I've been a full-time corporate healthcare attorney consultant for 47 years and have practiced in most all areas of healthcare law. When I retired from my law firm, Catmush and Rosamond, July 31st, 2024, I very next day joined the Hardenberg Group, which is now Sentact. As my wife tells me, I failed retirement miserably, although she likes to call it rewirement, which I think is actually a pretty good term. But as Ellen said, we gave our first presentation, the 1 month after the final rule became effective. And since then, I've given over 100 presentations around the country, various conferences and service programs, have been involved in a number of the key court cases around the country as well, whether as a direct participant or as amicus. So our combined experiences, I think, will be very helpful for the audience today. And to pick up on one other comment that Ellen made, every PSES policy that I've looked at falls pretty much woefully short of really understanding the full scope of the protections. And as Ellen said, to create a safe space within the organization to talk about adverse events and other responses to errors and patient injury, but as well as being proactive in that regard as well. And one of the attachments, or an attachment that you will be getting after the presentation, is an example PSES policy that was developed for one of my clients, that we have actually circulated to other PSO members. And you will essentially be blown away as to how broad the protections are in the patient safety activities, the kinds of committees, reports, and analyses that they are asserting the privilege for, typically under deliberations or analysis. So we'll be giving some examples of some of that throughout the slides.
I'm Ellen Flynn. As I said before, I'm Senior VP of PSO Services at Sentact Center for Clinical Excellence. I'm a nurse attorney with an MBA in Information Systems. I've had an incredible opportunity to work with some of the leading healthcare organizations in the country, and to have started one of the very first PSOs and to have led PSOs for pretty much the last 20 years. I am really excited, just like Mike here, about the opportunity for talk about building the safe space in your organization. My dream is to someday go into a healthcare organization that is open and honest and at the same time has a safe space for healthcare providers to learn and improve their care. I think all of it is very necessary. And I believe PSQA showed us how we can build a culture of accountability and learning all in one. Next slide. So our objectives today, we are going to talk about how to build this safe space within your healthcare organization, how to go about documenting the safe space and gain the PSQIA protections, how organizations can really create a well-documented PSES that really helps them learn, improve, not checks the box. Explain what voluntary activities going on within your organization, such as rounding, could occur within a PSES. We have quite a list of objectives here, and we plan to cover all this material in the presentation today. Next slide.
So just briefly, when we think about the Patient Safety Act, we're thinking about what kinds of information relating to improving patient care, reducing risk. And although a lot of times we think in the context of medical malpractice, right? Because that's where most of the cases come from. A discovery dispute in a medical malpractice case, where if you have had any dealings with those, the plaintiff is asking for everything, including the kitchen sink. But there's liability exposure in other contexts, and this is simply a list of other areas in which you have protected or information that can be kept privileged and confidential under the Patient Safety Act, because if it's privileged, it's not subject to discovery, it's not subject to admissibility into court. And so when you think about negligent credentialing, for example, and the information that the plaintiff wants to get access to, typically, and we'll talk about peer review and what can be protected under the Patient Safety Act, that information is not subject to discovery, making proof of a negligent credentialing case much more difficult. So it's not just in med-mal, these are other areas of exposure where the Patient Safety Act can be of some benefit to you. Next slide. Also, as you also know or should know, everyone is paying providers based on value, not based on volume. And consequently, unless you achieve or meet the outcome requirements, be it by the federal government in ACOs or value-based purchasing or in managed care plans, you're not going to get paid, or you're going to get penalized. And think about it, if the hospital is having a high readmission rate and therefore is getting penalized, why are you having a high readmission rate? That's something that should trigger an internal review or analysis, because in doing so, you are taking steps to improve patient care. And all of that information, all that discussion in trying to understand where are these problems and how do we fix them, can be kept privileged and confidential. It could be confidential under your state law, but clearly can be privileged and confidential under the Patient Safety Act, again, depending on the scope of what you describe as being protected within your PSES policies. And of course, if you look at the last bullet point, the CMS 5 domains or PSSMs, hospitals are required under Domain 4 to be in a patient safety organization. And we expect that if hospitals are not in a PSO, they will be, because of the expectation that at some point in time, there may be financial penalties for not satisfying each of the domains, including Domain 4. Next slide. And again, we're not going to go through all the fundamental key terms of the Patient Safety Act, but this is the key term for what's privileged, the patient safety work product. And when you look at the definition, any data, any reports, any records, any memoranda, any analysis, okay, that could improve patient safety, healthcare quality, or healthcare outcomes, can be considered privileged or confidential, either information that's being reported to a PSO or information, last bullet point, which constitutes deliberations or analysis. And you'll see in the example policy that we're sending to you, 80 to 90% of what can be kept privileged and confidential typically falls within the deliberations or analysis bucket. It's not information that gets reported to a PSO, such as meeting minutes, for example, and other kinds of reports or analyses. As soon as it's collected within your PSES, it's privileged, okay, not subject to discovery. So this is a key definition, and it's purposely very broad, hence your PSES, and what you're describing as protected can and should be very broad. Next slide. So patient safety activities, this is actually coming right from the Act. This is, again, very broad. It describes the process by which you implement patient safety activities, how you collect the information, how is it disseminated, okay, and used to improve patient safety, to encourage a culture of safety and a just culture, really, as well. As Ellen was saying, you create a protected space so you can have frank and open and honest discussions, which are all protected, designed to assist the provider, designed to improve patient care. There's an example in New York, the New York peer review statute, for example. If Dr. Callahan shows up before a peer review committee to talk about my post-op infection rate or that unexpected death or any type of adverse event, anything that I would say in front of that committee is discoverable if I get sued. So in New York, under the state law, physicians don't say anything, not even to defend themselves, because it's all discoverable. But under the Patient Safety Act, that information, those discussions, those minutes can be privileged and confidential, not subject to discovery. And when the hospital implemented a vibrant and comprehensive PSES policy and educated their physicians, suddenly they're having discussions in a safe place for peer learning, designed to help that physician get them back on track. Yet the physician's perspective, which could be useful for improving patient care. Okay, so that's what your policies are designed to do, create that safe space. Next. And again, this is just another aspect of patient safety activities, which again is defined and should be defined in your PSES policies. Next slide. And this slide is here because of the importance of being able to share PSWP across the entire enterprise. So this is a slide where the health system is kind of the corporate parent or the sole shareholder of all of these different provider boxes. And so hospitals that initially were the only members in the PSO, they're now expanding and applying it across the board. And because obviously you want to maintain continuity of care, you want to be able to share privileged information about a patient that is going through perhaps all of these boxes, okay? Or a physician who's providing services in some of these who may be having issues. That's important patient safety information. And under the Patient Safety Act, PSWP, privileged information in each of those entities can be shared across all of the entities. It's not a waiver, as is sometimes the case under state law. It's all protected. It's all considered PSWP. And you got to share that information, right, in order to improve patient care and reduce risk. Next slide. This is some recommendations in terms of, and we'll unpack this as we go, and Ellen's got some great slides to assist in how you develop your PSES. But what I've always recommend is that you inventory all the reports, analyses, committees involved in all patient safety activities as a starting point. In the example policy that you'll get, this system listed 55 committees that were engaged in efforts to improve patient care, okay, reduce risk. And they did this by scouring all their different policies. Because keep in mind, especially if you're part of a system, You may have system policies. You'll have hospital policies. But if you have multiple hospitals, my guess is they have different names, different kinds of committees, different kinds of reports. And so you want to be able to capture all of those reports, all of that information within your PSES. Um, and so doing that inventory is an important first step. And then you decide, okay, what do we have to report to the state? What do we want to keep protecting? You get to decide. It's a voluntary statute in many ways. And there's no one way of creating a PSES policy. Ellen, through Sentac has example policies. We're sending you example policy. And the reason we're sending you the sample is it should trigger or spark some understanding that, oh my gosh, we too could be adding those committees. We too can be adding those other patient safety activities that we didn't really think we could because, oh, geez, you have to report it to a PSO to be privileged. Well, that's not true. Deliberations or analysis is actually the biggest bucket of PSWP that health systems have. But it really is then designed to not just be able to assert privilege protections, but it also educates, the individuals, your workforce members, on how they collect, how they generate, how they share, how they use that information. So there's operational issues. You have a peer review track or quality track. Again, it's not seeking or requiring that you recreate your whole system. It's really what you're doing already, just that you're capturing those activities within a document and identifying the process from A to Z in terms of ultimately what are you reporting, what are you treating as deliberations or analysis. But again, you make that determination. And when we have these policies, and you'll see the example, we list what are we reporting, what are we treating as deliberations or analysis. And again, it's also then an effective tool. So when you get into these discovery disputes, and I've been involved in many of these working, with defense attorneys, you can say, Judge, what the plaintiff is seeking is specifically identified within our PSES policy. So we're not making this up. We're treating this as privileged and confidential. And through our policies, through the affidavits that identify, hey, this is the data in which was collected or created. This is how it was used. It went to these committees, et cetera. It gives the whole paper trail to an uneducated judge who probably knows nothing about the Patient Safety Act, knows nothing about your quality policies and procedures. And so it's a wonderful document to both educate internally and externally. Okay. Next slide. And Ellen, this is you.
This is an example of a data inventory. Those of you quality, safety, regulatory compliance, I'm sure you're all very familiar with doing data inventories. My recollection of doing one is they can be overwhelming. There's so much quality, safety, other activity going on in your organization. So my word of advice is just put down the big things, get started. It doesn't have to be perfect, but really kind of walk through what are we doing to improve patient safety, healthcare quality, and outcomes. And free yourself up. It doesn't have to include everything. And then walk through why are we collecting this data? Is there an external obligation? I think that's really important. You want to meet your regulatory obligations outside of your PSES, but I think people would be shocked how much voluntary activity is going on. There's two pathways, and most of you are already working with the PSO. But it's either the reporting, which is data you're collecting, or the deliberation and analysis pathway, data that you bring in and you're analyzing how to make care better. What's the priority? I'll show you a process that I sometimes walked through to help me think about how important is this data to report to the PSO. And then I may be collecting something that the original document, I needed to meet a regulatory obligation, but it tells a story that I want my PSO to see and incorporate into my annual feedback report. So again, have fun with it. It doesn't have to be perfect, I guess is my only advice for doing a comprehensive data inventory. Next slide. So this is a great example. And Mike, I think, is the one who gave me this thought years ago about above the line and below the line. So CMS has, in many states, a requirement for a event report if incidents happen, but they never tell you, I went searching and CMS that I can see doesn't say what needs to be in that event report. So this is your opportunity. What do you want to be in that event report? I think about when my state would come in when I was running quality, safety, regulatory compliance, they would say, show me the 5 people who fell or anyone who fell in May. And I had to have enough data so I could give them that information and lead them to the medical records, which aren't PSWP. On the other hand, all this information that is truly your deliberation and analysis, why did this event happen? How could it be improved? How could care be improved? That's patient safety work product that I would like to have privileged, confidential, and not share with regulators, the courts, etc. And I think, go to the next slide, Danielle. I think this is such an important point. Meet your regulatory requirements outside the PSES. So have your frontline reports so that you can show your regulator something. But then you've got all this learning and improvement data, your deliberation and analysis within your PSES that they're not entitled to see. So in my organization that I created, if the state of Illinois comes in, I've got my frontline report with them and they'll say, show me your falls. I can say, here's the 5 people that fell this month. We can go to the medical record and I can give you the actions taken related to those cases. Because again, actions taken are not PSWP. I think in the early days, what ARC reminded me of, really importantly, when I tried to design this with people is, if you try to throw the entire kitchen sink within the PSES, be prepared to lose everything. So really think, what do I need to meet my regulatory obligations outside the PSES? But there's so much that you can place within it. Next slide.
By the way, if I can make a comment, the HHS is on record in their May 2016 guidance as saying that government agencies cannot require you to turn over PSWP in order to demonstrate compliance with QAPI or another state statute. But you have to obviously establish compliance, and usually you can do that through non-privileged information. Okay. And that applies both at the state level, not just at the federal level. Sometimes the state surveyors get very aggressive and they say the Patient Safety Act as a federal law doesn't apply to us. Well, it does. It does apply to all government agencies. So just bear that in mind. And even the Joint Commission has taken the position that they can't require you to turn over PSWP. There's an exception of turning over PSWP to accrediting bodies with some stripped out information. But just bear that in mind for those of you, because we've seen too many instances where the government comes knocking on the door, demands everything, and uneducated people turn over documents which in fact could be in our PSWP. And once it's disclosed, then who knows where it ends up. So anyway, sorry, Ellen.
Thanks, Mike. This is one model that I like to use to really help me prioritize what do I want to report to a PSO. It's kind of funny. I always think of this one general counsel of our membership when we were having a discussion years ago. He said this really gets down to, is the juice worth the squeeze? Do I really want to invest in the time to report this case to a PSO? And he gave me a couple really great examples where he believed the juice was not worth the squeeze. There are cases out there where workman's comp cases can be protected. He said, I don't want my team all busy trying to protect a workman's comp case. I have insurance for that. I want those big ticket patient safety events reported, and I don't want to distract the team. His other example was visitor events. He didn't think that that was a good use of his team's time and energy to, say, report a visitor fall, etc. He really wanted big ticket patient safety events. So again, it's each of your organizations and figuring out with the resources you have, what's important for you to report to the PSO. Next slide.
Or treat as PSWP, right?
Mhm. Good point, Mike. Because everything does not need to be reported to the PSO, as Mike is making the point. If deliberation and analysis is conducted within a PSES, your safe space for learning, it can be maintained there and does not require reporting to the PSO and becomes PSWP at the moment created. So getting to this safe space for learning, making healthcare better. Here's an example I would do in my theoretical organization. So everybody's got to do OPP, FPPE, and I would do enough to demonstrate that I did a really credible job of appropriately reappointing practitioners. And if somebody fell out, they would go into an FPPE process outside the PSES, information that would be available to a regulator if they came in. On the other hand, even these same exact indicators, why wouldn't we make a safe space for learning where I kind of see on this left side, the OPPE, nobody's going to contact a physician unless his care is below the standard of care. Wouldn't it be incredible if I'm looking at my readmission rate and I'm thinking, oh, I'd just like to get it a little better. Couldn't I make my care better? And look at Dr. X. His care is a little better than me. Maybe I'm going to go and talk with my peers and see how my care could get better. Really kind of employing within your PSES and your safe space for learning a safety two approach, learning from what went well. Wouldn't that be a novel concept for all of us that do peer review or peer learning? Next slide.
So this is a little duplicative of what we said before, but again, gets to the policy development. You want to be fairly specific. We've seen a lot of PSCS policies that are just very vague. Like PSWP is anything that relating to improving patient care, reducing risk. Well, okay, exactly what? What are we treating as PSWP? And so the purpose of having detail, again, is to educate your individuals who are responsible for using privileged information to carry out a responsibility. What is being treated, because you have privacy and security requirements around that privileged information. And just as you would over information that's privileged under your state statutes. But the reality is the Patient Safety Act protections cover many more activities, many more kinds of reports than does your state law. Okay, so anything that's privileged under state law is going to be privileged under the Patient Safety Act, but not vice versa. Okay, so you want to be fairly specific. And as you'll see in the example policy that we're sending out afterwards, it's very, very specific and very procedural. It's describing the process. And as I was saying before, if I've had clients say, well, can we go to court simply because we have a contract with a PSO and claim that the information being sought is privileged? And I said, well, theoretically, technically, You don't even need to document or have a specific PSES policy, but judges need to touch and feel. You have to educate them, and to walk in and just making claims that something is privileged using generic information or information that could or should have been in a policy is really going to hamstring your efforts to establish that the privilege applies. So as we said, and sorry for repeating, inventorying and as Ellen said, prioritizing. Okay, does every single thing that triggers an incident report need to be privileged? Okay, need to be reported. I mean, you get to decide where you draw that line. And again, you've got limited resources. So what makes the most sense in terms of your particular hospital or your particular system? Next slide. Sometimes what we also do is put at the bottom of these documents, as you probably do under your state law, privileged and confidential under the Patient Safety Act. Okay. And again, your state privilege and your federal privilege, they're not mutually exclusive. You can apply both privileges if they apply. So I'll give you an example. In Illinois, which is the Medical Studies Act, there is case law now that says, for example, let's say there's an unexpected death which would trigger typically an RCA. In Illinois, let's say in Illinois, the RCA was initiated immediately. Case law says it has to be first authorized by a peer review committee or designee. So let's say we have a hospital that's in a PSO and has within their PSES policy that RCAs are going to be PSWP. RCAs, in fact, are specifically referenced in the definition that we went through before. So if that hospital didn't initially authorize the creation of the RCA, in Illinois, that is not privileged because there was no authorization. But under the Patient Safety Act, which doesn't require that authorization, that RCA would be PSWP. If they did authorize, that's an example of where both the state privilege statute and the Patient Safety Act protections would apply. And there are a number of court decisions which have recognized that under the circumstances, if the requirements are met, both the state statute and the Patient Safety Act can apply to the same document, the same activity, et cetera. So bear that in mind. But you always want to say including but not limited to, because the reality is your policies and what can be protected. You establish new committees, new proactive efforts. We have a client, its radiology group now is creating a proactive assessment or study regarding their reads in order to improve patient care. It's not related to responding to an adverse event. It's a proactive activity, but again, it's designed to improve patient care. So now, before that activity gets implemented or incorporated into the PSES policy, because it's a new activity, we have, language within the charter, within the committee, identifying that this is patient safety work product and deliberations or analysis, okay, if that's what we're choosing. But you need to update your policies because your activities change all the time, okay? And describe your pathway. It's important that you identify, is it deliberations or analysis, or is it being reported, okay? That makes it easier for the court. It makes it easier for you internally because you may be treating those differently in terms of the process used to report versus what you're treating as deliberations or analysis. Next slide. And again, I would say 80 to 90% of hospitals that have a fully developed PSES policy, 80 to 90% of what's privileged is in the deliberations or analysis bucket. And we do have courts recognizing deliberations or analysis as an acceptable method. I think initially we were on a call a day with a client where I think the general view was out of the box, everything has to be reported in order to be privileged. That's not the case. And we have court cases now that have accepted deliberations or analysis as an acceptable method. In fact, Rumsey versus Guthrie Clinic was a federal court case in Pennsylvania. It was on diversity, so a med-mal case brought into federal court based on diversity, where it was a missed MRSA infection that led to a serious injury to a patient, which then triggered a review by an infection control committee. And the plaintiff sought access to the committee minutes. They wanted to depose the individuals on the committee that looked at this MRSA infection, and they asserted both the Pennsylvania state peer review statutes as well as the Patient Safety Act. In fact, and a report that was done by Vizient, which is now Sentact, and the court said this is the epitome of deliberations or analysis. Okay, so they denied the motion to compel, and they could not depose the individuals on that committee regarding their discussions, their deliberations or analysis. Okay, next slide. Fun.
So this is a really important point. Again, I'm driving home the message. You have to meet your regulatory obligations. Your regulatory compliance people know what they need to do to check the box. And I do think it's interesting because prior to PSOs, I worked in quality and safety. I staffed many of these committees. I took minutes. And when we had a really serious case to discuss, those may not have necessarily made it to the minutes. Those made it to an executive medical staff session. I would hope today what those executive medical staff sessions have come to be are PSES sessions where the whole multidisciplinary team can discuss how could we have provided better care. Go to the next slide. This is the central model where the first one was central, everything siphoned off into PSES committee. I don't know how practical that is. I don't know that you have the expertise at one committee and you can bring all those people together multiple times in the month. How I would see it happening and how I saw it happening all the time in healthcare organizations, even before the Patient Safety Act, is you have all your committees, but then when you have something really specific where you want to voluntarily talk about how could we make care better at our organization, you now have the opportunity to have a PSES session. And it's kind of funny, years ago, I talked about this process, and one of the CMOs said, we had those executive sessions too, and we used to color the executive sessions on pink paper and the other ones on green. And Joint Commission, CMS, etc., only saw the green minutes, and the pink were for us. Those are the Patient Safety Evaluation Committee, and really hoping that you can have the whole patient safety team there talking about how care can be better and improved in a safe learning space. Next slide.
And what we're also seeing is that systems are now creating a committee, a patient safety committee, with representatives from each of the hospitals, right? Or a common credentials committee, right? That's reviewing the credentials of individuals. And so you're seeing efforts at systemness, right? Standardization, collecting data from all the different entities, be it for pharmacy issues or whatever that might be. And again, as we showed that one system slide, that information can be shared across the system, can be collected from each of those entities and reviewed and analyzed. Yeah.
Can I add, I don't think it's a new activity. I worked at a couple of really large systems. We were doing those things years ago at the health system I did. We had teams from across the whole entity, physician leaders, nursing leaders, talking about how to improve care. But we did it with no protections. Now there's this great opportunity to turn those into safe learning spaces.
Well, you're also just that much more progressive, Ellen. I don't know what to tell you. So, because I'm involved in a number of where they're trying to evaluate physician performance in a system that's really spread around in different locations, and so we're designing a system so that that information can be collected, can be reviewed, can be funneled up to a system-wide committee. And again, that would be more difficult under the state statute, whereas under the Patient Safety Act, it's providing a broad coverages and broad protections that otherwise did not exist. So these next few slides, when we say example health system PSES, this is language that's taken from a client that I'd worked with, another New York system. And as I said before, the purpose of these policies is not to just give a stiff arm to the government or to plaintiffs' attorneys. It's to educate the people within the system that have to work with privileged information in order to carry out their responsibilities. And so they include descriptions, they include definitions, what comprises their PSES, what is the PSES? And by the way, there needs to be training. Training is important so that people understand what is their policy. So often I gave a presentation to another PSO in Louisiana, and it was to all their senior nursing officers, right, their CNOs. And I knew that every one of them was in a PSO. In fact, it was the Louisiana Hospital PSO, an annual program I was asked to speak at. And I knew all of them were in a PSO. And so I asked the question, and again, these are senior nursing officers. I asked the question, how many of you are in a PSO? I'd say there was 100 people out, maybe half of them raised their hand, meaning the other half didn't even know they were in a PSO. And then I asked them, okay, how many of you are familiar and have read your patient safety evaluation system policy? Only 10 of them raised their hand. I mean, these are chief nursing officers that don't even know what their policy says. And so that's really a common problem. And if you don't handle it correctly, if you're not following your policies, it becomes an issue, okay? So, the policies are designed to educate, but you also need training to the policy. And when you're onboarding people, they should be trained as well. And you may also want to use confidentiality agreements or requirements or policies, because this information, just like your state peer review privileged information, is very sensitive. Now, the good thing is, there's no waiver under the Patient Safety Act as there is with some statutes. If it's, in some states, if it's, shared outside of the committee structure, it can be waived. Well, it's never waived under the Patient Safety Act, and PSWP can be used for any purpose within that entity, okay? So even HR can access, or someone that's just involved in claims or litigation management can access patient safety work product. They don't, but then HR, you don't put PSWP in the employment file, right? They create their own notes, their own investigations outside of the PSES, because that information won't be privileged and can be used to defend in case, you fire Dr. Callahan and he brings an age discrimination claim against you, for example. But again, so this is language in a policy. Next slide. And again, these are other terms, key components of the PSES. So they talk about the collection of data, the management of that data, what is included as PSWP, talking about the internal deliberations or analysis, and reporting to a PSO. So describing the process, the use of PSWP within the facility. Next slide. And again, this is the definition, right? reminding people this is how PSWP is defined. And you'll see in many policies, they're actually taking language of those key terms. So what is patient safety work product? What is privilege? What's not privileged? As Ellen said, medical records are not privileged. You don't want to claim everything is privileged, as Ellen said, because it's not, okay? And if you go overboard, you're really undermining your credibility. At the same time, trying to recognize the broad scope of what could be protected. Next slide. What is not? Again, this is to educate the people within the organization. Patient complaints and grievances. That typically is not going to, you have those communications, right? We talk about candor, which is a whole other discussion about, disclosing when there's an adverse event to a patient and its family. Those communications typically, you're not going to treat as privileged, but a patient complaint or grievance could trigger a review, right? Like, okay, we need to look into this complaint, okay? What were their quality of care issues? What were the issues involved that resulted in the grievance of the complaint, okay? So those communications initially in the back and forth are not going to be privileged, but if you're doing an underlying analysis, think of a mandated report. There are many states that have mandatory reporting, New York, California, Texas, and other states. Typically, that's on a form. It's a state mandated form. You fill it out. And to Ellen's point, it's typically just factual, right? So you meet your mandated reporting requirements, but there can be an underlying analysis as a result of that event which triggered the report. But the underlying analysis that resulted from that incident can be kept privileged and confidential, okay? Assuming you don't also have to disclose that to a regulator, okay? So again, incident, there are these reporting requirements that you have to meet. But as Ellen said, if it's important enough, a copy of that mandated report can be, sent to the PSO, which may be of value to the organization and to the PSO as well. Next slide. And so when we talk about committees that could be considered, whose work product and discussions could be PSWP, this is simply a sampling of the committees which this particular system identified. And it was a result of interviews, of meeting with CMOs and vice presidents and people in quality and people in risk, and looking at their quality plans and quality plans. And as I said, this is just, a smattering of committees that they identified. The example policy that you will be receiving, that particular system identified 55 committees, okay, which they've listed within their deliberations or analysis bucket, so to speak, okay? And so again, you look at the committees, look at the purpose of those committees. And it may be that not everything that the committee does is really qualifies as PSWP. So maybe like an MEC meeting, look at the agenda of a medical executive committee. It may be approving a bylaw. It may be developing a conscious sedation policy, updating another rule or regulation, or meeting with Dr. Callahan to talk about a lot of his adverse events that have occurred within the last 6 months. So a portion of that isn't going to be privileged, and another portion can be privileged, perhaps under state law in addition to the Patient Safety Act, okay? So again, you have to look at the committees to see, are they really doing something to improve patient care and reduce risk? Next slide. Examples of PSWP, and again, the examples could go on and on and on. So quality reviews, peer review activities we'll talk about because there's a whole section on peer review, incident adverse reports, RCAs. Ellen and I had a really interesting discussion about RCAs, what do you report of an RCA? So an RCA obviously typically gets triggered by an incident. The incident report is probably going to be reported because most hospitals report their adverse event or incident reports. But now you're in an RCA mode because it was a sentinel event or something that qualifies to do an RCA. Typically, the investigation, the review, and the discussions, be it through minutes or whatever, that are conducted as part of the RCA, you're going to treat as deliberations or analysis, okay? But, what would you report? So Ellen, I know that some of your members report aspects of an RCA to Sentact. So can you describe,
Sure.
what that'd be?
So many of our members will enter the event. That's kind of like the first bookmark. If they conduct a fact-finding session, they will send that in. And then there's a whole lot of deliberation and analysis that goes on, even emails, etc. All of that occurs within the PSES and really not required to report. One of the models, again, the deliberation and analysis doesn't need to be reported. The first two steps do. One attorney recommended to us maybe the very last step, reporting. So what did I learn by doing this RCA? I really think it's a cool model. I'll show you it in our slides a little later, but it really triggered me if I were working in a hospital. That would be helping me in an ongoing manner prepare my annual evaluation. What did I learn? Am I seeing any trends and patterns from what I'm consistently learning from RCA to RCA? Are there deja vu events? I think much more than just sending a full-blown PDF to the PSO, really thoughtfully sending in your event, investigation, and then what did I learn about this event? And we'll talk about that model a little more.
And oftentimes, as a result, go back to the slide. A lot of times there is an action plan that is created as a result of the RCA. Some hospitals won't treat the action plan as PSWP. So if CMS comes knocking on the door because of a Matala violation, a patient complaint, whatever that might be, they'll say, well, we're not going to turn over the RCA. It's PSWP, and HHS has said you can't require us to turn over patient safety work product, but here is our action plan that we will share with you. Okay, and the action plan has enough information on it that it should be able to demonstrate compliance along with other non-privileged information with whatever the regulatory standard is. The point of this is you get to decide where you want to draw the line. Okay, there's no one way of how you do it.
And can I add, Mike,
Yeah.
probably, with my action plan, having done them many times in organizations, I would probably, my recommended actions, until they were actually taken and completed, I might leave within my PSES and consider it patient safety work product. It's funny, years ago when I first applied for a job at UHC, I had been working in a hospital and I actually had this plan I would consistently track with 200 incomplete actions taken. Not a good model, but in those days, somebody was surprised somebody even knew of 200 safety actions to take. So I think it's important because we come out of RCAs, we have really big plans. Some of them are really expensive. We really need to make sure before we finalize that action plan and make it discoverable that we can take all those actions we're planning to take.
Absolutely. I'm going to talk a little bit later about FPP and OPPE because I know that you obviously have to meet your regulatory requirements. So the criteria that you're using, obviously is not going to be privileged. Okay, the stats in terms of that were identified in terms of how many were on PT, certain stats aren't going to be privileged. But if there's an adverse event in the middle of an OPPE or FPPE, that may then trigger a deeper dive analysis, okay, that depending on your policy can be treated as PSWP. Okay, so again, You really need to understand what are your regulatory and accreditation requirements. What must you show to establish compliance? And there's a lot that you aren't required to show or demonstrate that can be PSWP, but you make those judgments. You decide where to draw the line. I want to make a short comment on risk management. I remember giving a presentation years ago that ARC happened to listen to. It was really interesting because then I got a critique as to, you know, what the presentation and the information, and they jumped all over this comment about risk management. Risk management specifically can't be PSWP. And I said, don't look to the title of the individual, look to the activity in which they are conducting, okay? So yeah, if all they were doing was claims and litigation management, no, that's not going to be privileged under state law, much less the Patient Safety Act. But there are many risk managers that do engage in quality of care activities, okay?
Mike,
And
can
yes.
can I add something that ARC said to us at one of the national meetings? And not that I totally agree, risk managers do a lot of patient safety activities, especially clinical risk managers. But they said if you don't want to get hauled into court, think about what you call things because of that perception issue. You know, would you
Right.
rather stay out of court and be doing patient safety activities or prove that your risk management activities were really patient safety activities in court?
Yeah, I mean, and sometimes people have changed the job description of risk management to include, you know, their patient safety type activities. So you can say to a judge, look, Callahan's role covers safety. It also covers claims. Okay. And so, yeah. But again, just looking at a term, you know, doesn't, you know, you get knee-jerk reactions from courts. So, you know, you just have to be mindful of that. Emails, text messages, that all can be, you know, PSWP. We even have some clients that have an email system where it will specifically say at the bottom of the email, patient safety work product. Okay. Now, again, you don't need to have that self-serving language in order to perfect the privilege. It's a best practice, but it's not a requirement. It's just that you'll get plaintiffs' attorneys say, well, I don't see the magic language on this particular document, therefore it can't possibly be PSWP. So you try to reduce the number of arguments that the plaintiffs and others are going to raise to try to, you know, have it knocked out or have a court rule that it's not privileged. Next slide. So this is other language that you'll see in the policy that we're going to send you, okay? And it's really, I think, good because it captures the purpose and the scope and the purpose of the Patient Safety Act in terms of the kinds of information and the categories of information that can be kept privileged and confidential. So just look at the first one: quality assurance, improvement, patient safety activities, communications, written, oral, or digital, and information reported, developed, or captured directly in minutes by individuals or committees for activities relating to improved patient care, reducing risk. And you'll see in the policies, they list 28 specific patient safety activities relating to that kind of catch-all intro paragraph. Data and documents that support quality assurance, improvement, and patient safety activities that are created, derived from, or obtained during the above activities. You're never going to have a PSES policy that lists anything and everything done within the facility, okay? So we cross-reference the policies sometimes, you know, rather than cutting and pasting and sticking in your main PSES policy. The reality is, your PSES is probably multiple party policies. It's like your event reporting policy is typically separate, right? But you cross-reference saying that's all part of our PSES system and process, okay? So think of it as potentially multiple. You'll see a reference. Go to the next slide. So look at the first paragraph. The development and implementation of committees and programs to address quality and patient safety improvement, whether permanent, ad hoc. You have a lot of ad hoc committees, right, that get created on the spot for a particular purpose and may not find their way at that particular point in time in the PSES policy itself. And conducted by the department, right? Departments, divisions, groups, both at a hospital level and a system level. They list 55 committees, you'll see, in the policy, the example policy you're being sent. Any committee not listed but included in the system QAPI policy and QAPI policy of any affiliated entity. Again, remember, you still have to meet your regulatory requirements as per QAPI and as to other state regulations. But I have found a lot of these QAPI plans list committees and other activities that really aren't captured. This one client has a 10 hospital system. Each of their affiliated hospitals has a QAPI plan. Each of those QAPI plans is the names of different committees, different reports, different analyses. So you want to be able to capture those activities as being privileged and referenced in your PSES policy. Another system, recognizing that each of their hospitals have different committees, different reports, they actually have a supplemental PSES policy of the system-wide policy, and then they have a supplemental policy specific to that hospital, which lists those committees, lists those reports, because it's going to be the hospital that gets sued, right? Or the hospital that gets investigated, not the system necessarily. So again, it's an attempt to be broad and specific enough, okay? Next slide. What is peer review? Peer review, and Ellen, please feel to chime in. Peer review is a really catch-all for a lot of different activities. And the reason we created these slides is to, again, get you thinking about what are the kinds of activities relating to improving patient care and reducing risk within a hospital. And you may or may not call it peer review, but again, to me, it's kind of a catch-all a term. And so unpacking it, again, process of improving quality and safety, privileging and credentialing, that tends to be, very document oriented, but there are activities where, for example, if you're looking to see if Callahan should be doing a certain surgical procedure, so you're going to do perhaps a retroactive review of cases to see, whether I really am or should be qualified to exercise, let's say, a new privilege. Well, some of the analysis that goes into privileging credentialing can, in fact, be treated as a patient safety work product within your PSES. Performing a medical or quality assurance review function, utilization review, because if your overutilization can have an adverse impact on patient outcomes, right? So we within Sentact, there is the capability of profiling physicians through data collection through all these insurance companies that look at billing and coding issues, where they can say, do you know Callahan orders 40% more of X medication than does his or her peers, okay? And that could be a red flag. Is that overutilization? Is there adverse outcomes as a result of overutilization? So that can also be a protected activity depending on the purpose of that particular review. Concurrent retrospective review of cases, adverse events, okay? That's done all the time, especially in the context of maybe trying to get a physician back on track in the spirit of just culture, okay? Cases are popping up, you do a retrospective review, or maybe you're doing a concurrent review because issues have been identified. Again, that's a type of peer review activity that can be captured within your PSES and treated as PSWP. RCAs we've talked about. FPP, OPPE, I think I talked about that before. Next slide. Collegial intervention, okay? Again, in the spirit of just culture, having reviewed 300 sets of medical staff bylaws, which is not the most exciting activity, believe me. But the whole purpose is design peer review policies and bylaws where, again, we're trying to address an issue early on, okay, before it festers, before it gets worse, before we have to get into taking actions that might trigger a data bank report, right? Where you don't want to go there, or trigger hearing rights. You don't want to go there if you don't have to. And so we look at other type of what I call remedial measures, monitoring, proctoring, consultations, re-education requirements. Okay, and I don't view an FPPE as something that's reportable, if the physician decides to resign, but that's a whole different issue, a whole different presentation. I actually was on the executive committee of the data bank at one point in time. Interesting experience. Again, a discussion for another day. Certain research activities, okay, can be a patient safety work product. Dealing with impaired physicians, right? You have codes of conduct. You have disruptive behavior policies, okay? You're obviously engaging in those activities to protect patients, right? And so the outcome, the committees that are involved in these types of activities, that information clearly can be patient safety work product. Again, people aren't always thinking about what they can include, or that this is really a protected activity. It's probably protected under your state law as well. Physician wellness evaluations and activities. Again, these are just examples of different kinds of peer review. Next slide. Evaluating regarding performance, skill, technique, competency. Uh, you've got policies, right? You've got a peer review policy, probably. And it's an example where you can maybe cross-reference to certain policies that are in existence, right? And including that under your PSES umbrella, okay? So again, peer review investigations and hearings. This is an interesting topic, and it's a presentation that Ellen and I did for the American Health Law Association in February. Do you use PSWP for peer review investigations and hearings? I've been involved in, I don't know, over 200 hearings, when I was with the law firm. And, typically working with representing the medical executive committee in these hearings, I want a good record, which includes all of the reviews that took place leading up to the recommended termination. I need to have that record introduced into the hearing, because the hearing committee is there, but for the grace of God go they, right? They want to make sure that you dotted your I's, crossed your T's. You did everything you could to help that physician. He just didn't get it, and that's why he's being terminated. Well, yes.
Can I add with peer review, though, as we hopefully shift within a PSES to peer learning,
Yes.
I keep staring at standard of care. When I go to a medical provider, I hope I'm not just getting standard of care. I really hope I'm getting the best and safest care. And peer learning in a safe PSES gives us that opportunity to go from, yeah, I quite wouldn't consider that terrible. It basically met the standard of care, which to me is the floor of care, as opposed to the care we all want to receive and we're hoping that our providers deliver. We are creating with the PSES this safe space where our providers can truly learn and improve and are not afraid to share with each other a little bit higher level than just standard of care. To me, that's not where I'm aiming for.
No, I mean, you're absolutely right. And I think that is what is actually trying to be done, especially in a just culture environment, right? And so I know the title these slides have been peer review, but I think we can easily and should be using more the concept of peer learning, because I think a lot of physicians view peer review as like punitive, right? I'm being called on the carpet before this committee or that committee. And I do think
Exercise of futility, I've heard.
right. And so I do think, it is changing a focus, changing the tone. And I will say that at least I have seen over the years, not waiting to the last minute when you have no choice, but you got to get rid of a doctor, okay, because of their poor quality. But instead, and I think this is the industry expectation as well, we want to address those issues early on in a proactive peer learning, just culture environment. And so I used to say that of the 200 and some odd hearings I was involved in, 75% of them would not have been necessary if the physician felt comfortable to say, you know what, I made a mistake. Okay, I could use your help. And if the tone and the focus of the medical staff in the hospital is, yes, we're here to help you, we're not here to punish you. Okay, because punish you in hearings, no one makes. The only people that make out in a hearing are the lawyers, right? And you
True.
got and I've seen a lot of nasty hearings that have so chilled any effort to try to work with physicians or go through that process again. It has an adverse consequence. So so Ellen is right, and really think of this as peer learning opportunities. Okay. Next slide. And I think Ellen.
So as we talk about peer learning, I just think organizations that haven't really defined their PSES, haven't created this safe space for learning, are leaving so much on the table. I used to sit years ago in the old-fashioned state law medical staff peer review and nursing peer review, and I would be the letter writer between the two groups, and we'd use a year saying it was the nurse's fault, it was the physician's. It would be so incredible if everyone could get together in one room and talk about care being better. It's funny, Mike's talking about the peer review and the standard of care. I remember we'd fill out these papers on peer review and they'd say, maybe you should have done X, but we couldn't share that unless it was below the standard of care. The only person who saw it was my data analyst. So we learned a lot of medical facts, but the actual physicians probably never heard about how they could make care better. Again, I think OPPE, in addition to doing it for regulatory purposes, in a peer learning environment is so incredible. Same thing with our RCAs. Medical staff and nursing peer review. I worked with one nursing department, which I thought was really creative, where you could actually ask for yourself to be reviewed. I'm having a little bit of trouble with my organizational skills as acuity rises. And senior nurses in this governing board would look at your care and give you suggestions on how maybe you could provide better care, how you could mitigate some of your issues. And I mean, the whole point, I hear it many times on TV, but I think it's so important. We all want to go and get care that's better than it was yesterday and continually better. Same thing, I don't think we use grand rounds enough, but really that complex case where I don't even know if there was truly a safety event, but we didn't provide the care we wanted to. Isn't that a great case to bring the multidisciplinary team together? And how could we have done it better? Morbidity and mortality reviews, same thing. Really having this safe space where people can speak their mind. On the other hand, again, outside standard of care, you have to meet your OPP. I actually worked for a medical staff, and their term was when OPP was coming out, they wanted to know their batting average. So we would give them their OPPE on a regular basis. But just all this data that's out there, wouldn't it be nice to be feeding it to providers who can look at it and say, oh, maybe I could do X, Y, and Z, or I could talk to somebody. Same thing with FPPE. That doesn't happen, my understanding, unless things have really changed very often in healthcare organizations, other than when new providers onboard. But again, there's this great opportunity to look at care and decide, maybe they're providing standard of care, but maybe this care could be better in our organization. And that's over on this side. And then, of course, everybody has to do their state incident reports, RCAs, adverse event reporting. Next slide.
By the way, make a comment. We're going to try to leave some time at the end for questions, but we didn't say at the outset and probably could or should have. If you have a QA, a question, you can submit it. Yes, Danielle, through the chat, right?
Yes,
We
and
probably
we do
should have
have
said yes.
Oh, yep, we do have a few questions submitted. So
Oh,
you can
good.
submit through
Okay,
the
well,
chat or the Q&A.
okay, perfect. So we'll try to get to those at the
I've
end.
talked about this already. This is our model for sending peer review to us, peer learning, and what are you learning from doing these reviews? We have organizations doing it. Many times I will hear medical staff. I used to do peer review consulting and remember going into one academic medical center and the head of a department said, this peer review will never leave this office, count on that. Yet, when I say to organizations that want to send their peer learning to us done within a PSES, I don't care who the physician is. That doesn't really matter to me at all. All I want to know is what you learned from it, where we can feed that back in a feedback report to you and also on an aggregate level. Next slide. So there's so many of those databases out there right now where they're risk adjusted. You can look at your performance versus other organizations. They're really high quality. I think it's great to look at those data. If I had one of those systems and I were looking at that data, I would do it within my PSES. I think years ago, we would do it at the organization where I worked and people would say, don't open Pandora's box. PSES is a safe place where you can open Pandora's box and look at your provider, other providers, your competitors, and how can you learn from a safety two approach? Next slide. AI. This is if I were working in a hospital and of course, it would have to be HIPAA compliant and approved by my administration, but I would definitely have an AI tool within my PSES helping me improve the care. I would document it within my PSES, just great opportunity. I think it's going to fundamentally change our quality and safety work for the better. Next slide. Additional PSES consideration, define your PSO workforce. And I have to give Mike a lot of credit for this. Think about your committees that are PSES committees doing peer learning. Have you had them sign a statement that whatever is discussed in this room stays in this room? It's not shared outside of the organization. I think that's really critical and something many organizations don't do. I've even worked in organizations where at the beginning of a meeting, someone will read, so there's no question for anybody who was at that meeting that what happened in that meeting cannot be shared either beyond the meeting or beyond the organization. And then really set clear workforce expectations on just culture framework, mutual respect, psychological safety, peer support. I think healthcare is an incredibly hard job. And how do we make it easier for all of us to do the right thing? Next slide. Again, ongoing workforce reminder, whoever's your workforce, train them, make sure they really understand what you expect of them. And as Mike said, put disclaimers and label the data. Next slide. Questions?
By the way, I did see one question that was an important one that comes up all the time. Can you claim that a document is both privileged patient safety work product and attorney-client work product? The answer is a definitive no. Attorney-client protections apply to documents that are created in anticipation of litigation, which has nothing to do with the purpose of improving patient care and reducing risk. Okay. In fact, I've seen at least one or two court decisions which have pretty much said that, and you don't want a court to say, okay, we'll apply attorney-client. Oh, guess what? That can be waived, right? And it's more limited. So no. I've also seen in privilege logs, they claim the Healthcare Quality Improvement Act. Well, HCQA is an immunity statute. It's not a privilege protection statute. Okay. So yeah, so you
And
cannot,
Mike,
yes,
attorney-client also conflicts, at least in Illinois, I know definitely with state law, I've seen cases. Medical
you
Studies
froze
Act.
there for a little bit. Can
you hear me?
Yeah, you froze for a
Okay.
little bit. So could,
Attorney-client privilege conflicts with Medical Studies Act privilege in Illinois,
yeah, again,
just
they're
about
just,
everywhere.
yeah, they're different purposes. So what other questions that do we have, Ellen?
Yep.
I mean,
Yep,
Danielle?
we do have several other questions. I can read them down for you. So
Okay.
the first one being, if you send an RCA to DOH and it cannot be PSWP, can you have the deliberations and analysis of the RCA be PSWP?
If they're done within a PSES.
Yes.
Okay, perfect.
Now, again, you want to add detail to your PSES, but sometimes there'll be a request for information that isn't specifically listed. That doesn't mean it's not privileged. It just means you have to make the case as to why it's privileged. And you'll get arguments like that. Well, I don't see it on the list. You've got your 55 committees, but this committee isn't on the list, therefore what they do isn't privileged. That's not true, but it just takes more proof that no, that committee, here's what that committee does. Here's its charter. It clearly is involved in improving patient care. The fact that it's not on the list doesn't mean their work product isn't PSWP. So.
Perfect, thank you. And then the next question is, if you cannot waive PSO protection on work products, then is there any downside to sharing PSWP with regulatory surveyors other than they can cite it on a 2567, which becomes public, but your original PSES is still protected, right?
Could you repeat the question?
Yep. If you cannot waive PSO protection on work products, then is there any downside to sharing PSWP with regulatory surveyors other than that they can cite it on a 2567, which becomes public, but your original PSES is still protected, correct?
Okay, so first of all, I'm assuming that you're only sharing it because your attempt to share non-privileged information and policies wasn't enough to demonstrate compliance. There is this is the attorney talking, not ARC talking. There are a number of disclosure exceptions. Okay, so you can disclose your lawyer, right? You can disclose your accountant. You can disclose independent contractors. But a provider, a hospital, for example, can disclose its own PSWP. So in that circumstance, we've created a letter citing to CMS and even to a judge who wants to see your patient safety work product, because there's no exception that allows a judge to look at PSWP in camera. That's typically permitted under state law. But we say, dear administrator, dear judge, dear whatever, the information that we're disclosing is patient safety work product consistent with our policy and under the act, blah, blah, blah. But we are disclosing it under section 3.206B3, which allows us to disclose our patient safety work product for the limited purpose of demonstrating compliance. But as a reminder, you cannot redisclose this. It remains PSWP and it cannot be shared. Okay. So they're not supposed to post it on any public website. And by the way, FOIA is not, you can't obtain patient safety work product through a FOIA request. That also is specifically
prohibited. Licensing bodies can't require you to turn over information that they're investigating Dr. Callahan and whether he's going to maintain his license. Okay, they can't require you to turn over PSWP. So,
and from an ARC guidance standpoint, you're not allowed to release PSWP to a regulator. And with that said, what I've heard from attorneys who have tried is that CMS will not agree to not redisclose the data. That usually becomes the rub in the situation.
yeah, you want to find out, but at the same time, you know, do you want to be kicked out of the Medicare program? Probably not, although there knowing that rarely happens. So again, there's a lot of judgment, and you really need to have the appropriate team to kind of figure out what you're going to do or not do in response to a subpoena, a government demand for information, et cetera. So it's not a perfect statute, but again, HHS itself is on record as saying government can't require you to turn over PSWP to demonstrate compliance.
Perfect. Thank you both. We do have a couple more questions. I know we're at 3 minutes. I will collect these questions once this concludes for us to use in a future meeting on PSA. However, I will read you the next question. Can you use aggregate data from event reports that indicate a safety issue in a particular provider's performance to prompt peer review or further separate investigation?
Sure.
I think you need to outline, if this is OPPE and FPPE you're discussing, you really need to define what your triggers are, have a plan, ensure that you're applying it systematically and objectively.
But if the question is, can it be PSWP, certain components or reviews can be PSWP. Again, keep in mind your regulatory requirements, but yeah, that's one of the reasons why we aggregate, and analyze. I still remember seeing a slide of a client. They were tracking some kind of adverse cardiac issue, and they did this whole analysis of all their cardiologists, and they sent the results to each individual, didn't identify the results of other individuals, but they showed that if you were an outlier, where you were in that circle. And there were people that were outside the circle that were clearly outliers. So Callahan saw that he was an outlier. I didn't know anyone else's performance, but they don't like to be outliers, right? They get that information, is compared with their peers, and then the next step is, okay, what can I do to make me not an outlier and to improve patient care? So there's I think a lot of that data sharing, aggregation, and analysis that's taking place, and that can be PSWP.
There's another question. If event reports are filed for means other than patient safety, for example, as a means of retaliation against other providers, can you remove them from the PSES? I think that's the dropout provision. You can remove events reported to the PSES prior to reporting them to the PSO.
Well,
And then they're not considered PSWP and documenting the date.
Yeah, that's right. Again, assuming you treat it as a reporting event, not because if something's characterized as deliberations or analysis, it can't be dropped out. Okay. You don't report it, you don't have to report it, but you can't drop it out. I guess my question would be, would that even qualify, as PSWP, and whether that would be excluded. So complaints against your peers, which may or may not be justified, you're going to treat that as privileged or not. So that's kind of a first question, but a good question about your policy design. So.
All right, it does not look like we have any other questions, and we are at time. So
I think we have
a
couple more slides before we walk away.
Excellent.
Again, this is just, if you want to learn more about Sentact, which has many different service lines, including the PSO, you may want to go to the website. You'll learn more about it. These are just some of the systems, clients and members, just the tip of the iceberg, because there's many more than just the ones that are listed. Next slide. Again, this gives you a little more information about all the different service lines under Sentact for those who may be interested. And then if you have any questions, the next slide gives our contact information. Okay, again. And if anyone's interested in having a PSES policy reviewed or developed, designed, or interested in in-service educational programs, let us know. We're happy to provide that as well. So thank you all for signing on. And again, you'll be getting the slides and you'll be getting the example policy. So if you have any questions with the policy as well, just let us know.
Thank you.
Otherwise, thank you all.